This year's World Patient Safety Day is celebrated on the 17th of September 2025, and it's all about going back to the very beginning, with the theme Safe Care for every newborn and every child. We've prepared 2 special episodes for you, one on safe care of preterm babies and the other on paediatric medication safety. Hello, and welcome to Voices for Safety, a podcast from the NIHR Greater Manchester Patient Safety Research Collaboration. Today we're diving into a topic that doesn't always get the spotlight it deserves, but it's absolutely critical. That's paediatric medication safety. Around 6% of patients experience serious but avoidable harm during their care, and about a quarter of those cases are linked to medication errors. When we narrow the focus to children in hospitals, the numbers are just as concerning. Between 1 and 2% of children experience harm, and many of these incidents could have been prevented. So I'm pleased to be having this conversation today with a leading researcher exploring this topic, Dr Adam Sutherland, and with Heidi Ridgewell, a mum and advocate for paediatric medication safety. So Adam, can you introduce yourself?
Hi everybody, I'm Dr Adam Sutherland. I am Associate Professor in Healthcare Quality and Safety at the University of Bradford, but I'm also a Research Associate with the Yorkshire and Humber Patient Safety Research Collaboration. I'm a registered pharmacist, have been for the last 25 years. How did that happen? And I used to work in paediatric intensive care, so I used to look after the sickest kids in the health service. Back in 2017, I was fortunate enough to get funded by the National Institute of Health and Social Care Research to undertake my PhD, and I focused on what are the medication safety systems that are in place for kids in hospital. So that's how I'm here and I'm talking to you today, Lou.
Oh, amazing. Well, welcome, Adam, and it's great to have you on board. Hi, Heidi. It's so lovely to have you here today. And I know that you've got a lot to share with us about your lived experience as a mother, as an advocate for your son and for other families, and as a research champion. Can you tell us more?
I would love to. I am first and foremost a mum. My son is 26 years old and he has been unwell for the majority of that time. And part of our journey through his complex health, I joined a charity local to my area called Ryedale Special Families. And they were approached by Adam for parental stories. And therefore, I got in touch with Adam. In the process of this, the other thing that has changed is that I'm also now a family support worker for that same charity.
Amazing. Adam, I know you were with us at the NIHR Greater Manchester PSRC a few years ago for your PhD, so it's really great to have you back to talk to us today about the work that you conducted while you were here. Later in the show, we're going to dive deeper into your paper that's entitled They Take the Mum Off You When You Come In. And that was the result of your ethnographic study of parent experiences of medicine safety systems in English hospitals. But before we get into your findings, can you tell us a little bit about what you were doing when you first met Heidi?
Yeah, so obviously this was kind of into my PhD. One of the things that rapidly emerged, both in my own practice, my own understanding, and in kind of, the work that we did to set up that PhD, was that the parent voice is missing in a lot of patient safety research. And what emerged through my observational element of my research was that parents were essentially shoved in a corner and asked to just watch what was going on. And a big part of my research was we need to get the parent perspective on what's happening while their children are in hospital. And I think I opened a massive can of worms when I started that process. And I have to be quite careful about what I say here because I get quite emotional when I talk about where we went with this. For me, I was seeing, and in my praxis as well as in my research, I was seeing parents' perspectives being dismissed. So what I was doing was trying to recruit parents while they were in hospital to come and talk to me. So I was really struggling to recruit on that. And then it was actually another parent who also joined our parent working group, who worked with Ryedale Special Families herself, and suggested I contact a number of other charities around the area in which I was doing my research. And they introduced me to Heidi. And then we went from there. And Heidi then introduced me to some other parents. But yeah, for me, it was actually working with those organisations that are outside of the hospital that deal a lot with those families that go in and out. For me, was actually probably the single best thing that I did in the conduct of my PhD, because they introduced me to this world that I just wasn't familiar with at all. And then once I got into that world, suddenly a lot of what I was seeing in my research started to make sense. And I started to understand, I started to see then how I can explain what is happening and bring in, actually, the parents are really important here, and we ignore them to our detriment.
Yeah, to the detriment of safety as well, not only our own detriment as healthcare professionals and researchers, but to the safety of the patient, right?
Absolutely.
So Heidi, what led you really to connect with Adam? What was it about Adam's work that made you think, this is an opportunity that I think I can add to?
My son, so he was very premature. He was born at 28 weeks with not one, but two rare conditions. So we were well versed to being inpatients in hospitals and medications and surgeries and procedures. During that time, when 2011, he became extremely unwell. He was known to have various forms of epilepsy that were uncontrolled, and we'd tried different drugs to change that. And he became very, very unwell. That resulted in hospital admissions on an emergency basis almost every weekend, and it just became a cycle. And he would go in very unresponsive, vomiting, given saline fluids. He would seem to make a recovery, and then there would be conversations, and then he would go home often with his epilepsy drug raised, and he would pick up for a couple of days, and then the cycle would just start again. And this went on for months and months. We basically lost the whole of 2011. Yeah, it was very, very scary. I remember clearly that my husband and I stood outside the back door and we just said, we're going to lose him. We're going to be burying him, because we just couldn't break this cycle. And then during one hospital admittance, a young registrar took some blood. And then he came and said he'd found on the bloods a result that the medicine was making him toxic. And that was the cause of all these problems, which then led me to find out that it could have been preventable with another blood test and checking these levels a lot sooner. Ultimately, my son was then left with another condition. His body bears the scars of that horrendous period. So therefore, when Adam spoke about patient safety for children, yeah, my ears pricked up, because there's been many times where my gut has wanted me to say other things, but I seem to be constantly met with a barrier of your son's complex, which in our family often we say sometimes translates as we don't actually know what's going on. That's how it felt.
Yeah.
And doctors are doctors. They've trained for many years, rightly so. And as a mother, you sometimes feel that your feelings should remain squashed. And from that very first conversation with Adam, and then following meeting other parents, yeah, it's been incredible. Wow, we have such a powerful voice together.
You do. And obviously that's how we found you as well. And we know that you're quite a dynamic duo as for advocacy. But it must have been quite a challenge for you, Heidi, to go from parent to thinking, I'm going to work with Adam. That must have been quite challenging for you to not step up to that, but sidestep into that role, I suppose. Or was it not?
No, I don't feel it was. It hasn't felt challenging. It's felt right. I think sometimes, in life we go through things and hard things happen, and I always think there's an option, and we can either let it define us one way or another. Clearly, for my son, there was an error, and it was catastrophic. But I have to balance that with the amazing work that they have done. He's alive today because of the work that the NHS and the expertise and the money that went into keeping him alive. And so I have to balance it. And I understand as well. He is quite unusual, and he's quite a rarity. What I found working with Adam is that those feelings where, as a parent, your child unbelievably well, that you see those signs that alert you, that despite what they may portray on the outside, you can see those little subtle signs that say something is wrong. And actually, that became apparent working with the other parents and meeting them. Our stories, sometimes parents would talk and the rest of us are all sitting there nodding our heads. And yes, we understand, we all got it. And Adam embraced that. So it didn't feel challenging. It's been an absolute joy. Meeting up together on Zoom is one thing. Meeting physically in Leeds for the day was one of the most unforgettable days of my life. It was just so unique, but so wonderful to be in a room of parents where we all had that mutual understanding. So it's been a joy.
Heidi, when you've engaged with research, how did that impact on how you advocated for your son's health going forwards?
I'd always felt that I advocated quite well. I think Adam said about opening a can of worms. For me, it was a bit like lifting a lid off an internal box, because taking part in this and then listening to Adam and even little things Adam spoke about his previous life as pharmacist on the ward taught me so much. I think being a part of this and realising that this was a thing, we could change this. It wasn't just my experience. There was a reason for this research, and that's because there was many families like ours. I clearly remember sitting at my kitchen table having the first Zoom meeting with Adam and thinking, you're allowed to have a voice. You're allowed to speak about this. You can talk about this and you can say it was wrong and you can say that things can be better. And yeah, that's what I'm intending to do. Working with, I primarily work with parents whose children will have an additional need of some sort. So it's been valuable in that respect as well. But yeah, it has changed. I feel a little bit more diplomatic.
And what a legacy to come out of this, this really challenging time for you, Heidi, and then meeting Adam and getting involved in work has led you to be able to help other parents. And that's a beautiful legacy to be carrying forward. I would like to talk about the actual research that you have done together. I read your paper, "They take the mum off you when you come in," and that is such an amazing quote. So, Adam, could you tell us a little bit about what your key findings were in that work and how you went about that work?
Yeah, sure. So basically what I did and approached my question around medicine safety as, do you know what? I just need to watch what people do in real life. I can count medication errors and I can do all sorts of things till I'm blue in the face, but that's never going to explain why things happened. And my question was a why question. Why do we just do the same things again and again and again? So I gathered myself together and girded my loins to go and basically observe medication practice in a number of hospitals in the north of England, because I just wanted to look at what the culture might be in each of those organisations and how that might affect the way they look after kids. What I mainly observed was around kind of medication. So I observed medication rounds, I observed doctors, nurses on their rounds, doing their normal medication work. And I started to see that actually parents were a really important part of this as well. So one of the big findings of my PhD as a whole is that actually parents do a lot of medication administration, whether it's allowed in the rules or not. And I think that's simply because nurses are busy. They can't do it all. And a lot of nurses acknowledge that mums and dads know what they're doing. And actually, if they're around, I'm going to let them do it. But that started to create very, very interesting dynamics between families and caregivers, because quite frequently families did what they would do at home. And that sometimes isn't going by the rules that you see in the hospital. So then I start thinking about, well, okay, where do those rules come from? Why does that happen? But interestingly, a lot of those guidelines aren't really looked at because most people run on memory. They just work by what's in here, what I've done before, that's fine, I can do that, which is what parents do when they're at home. So when families come in, they have their routine for their medicines. And I observed one family where diazepam, which was being used for muscle relaxation in a child with cerebral palsy, they would administer it over a waking day, and the child was fine when they were asleep. But once they got into the hospital, they started missing doses. Things were being done at wrong times, and mum was very frustrated on a ward round. Look, my child is dystonic, they're unwell, they're going to be in hospital for longer because you won't let me give the drugs at the right time. Similarly, medication prescribing was often wrong, because as clinicians, we rely on written documentation, but that documentation is always out of date the minute it's written. And there are phone calls between consultants and between families where doses are changed, but that's never captured in a database somewhere. So I would observe situations where parents were being asked to give what they knew was the wrong dose of medication, and parents having to refuse to do that, and nursing staff getting huffy, and nursing staff going, oh God, I'm too busy for this, but I'm going to have to do it because mum refuses to do it because she says it's wrong. And you start to see then actually parental competence is the minute you're ready to go home, 4:00 on a Friday afternoon, and we need the bed, we're quite happy to send parents home with a bag of drugs and no instructions, take them as they are on the label. As soon as they come in, we assume that they're no longer competent to give that. And a word from a parent I observed was they just put me in the corner and expect me to watch, and then wonder why I get angry when I watch things going wrong. So there is a huge aspect there around there's a huge challenge there between the way we communicate amongst ourselves as healthcare practitioners and the way we involve our parents in that. So it was very transactional, and parents held everything. They knew everything. And we would only really talk to parents when we wanted information. We didn't actually involve them proactively in any of those care discussions. There was very rarely a question about, okay, and what times do you take these? In fact, one of the clinicians I interviewed basically said they gave a prize to a junior doctor because, they recorded all the medicines based on the family's routine, not on what they would do in hospital. And I'm just like, well, wouldn't that be normal? Wouldn't that be the right way to do it? But again, those rules and structures.
So what would be the normal process for going into hospital? So how would that play out in hospital in a sort of standard kind of setting? Who decides on those medicine times?
So the drug history will usually be taken by the admitting doctor as part of their clerking, who'll just write a list. And if you've ever seen a medication list written by a doctor, it's just drug dose. No time, nothing. So paracetamol, 1 gram 4 times a day. So no timings there. They would then, depending where they work, prescribe those on their electronic prescribing system, and they're all configured with standard dose times. So there would be no direct need for a medical practitioner or a prescriber to intervene to change those times. The computer will just do it for them. Similarly, if they're prescribing on a paper chart, they're just going to write paracetamol 1 gram and then tick boxes or circle things. So they want to do something as quickly as possible because they've got 60, 70 other patients to look after. They've got notes to document the bleeps going off. There's a sick kid in A&E that they need to go and see. So they're trying to balance their workload based on need. What do I actually physically need to do with everything else that they need to do? So by acknowledging and bringing in a family's routine, that takes time.
But I suspect in many areas, when we're talking about children, routines are really important.
Yeah.
And important to the family as well, to feel that they, I suppose, have some sort of sense of place in what's happening in a very different environment. Are there particular challenges about changing a medication routine for children compared to whether this was an adult?
So going into hospital is stressful enough, but changing that daily routine, particularly for patients and particularly for children with complex needs, where those routines, you think about neurodiverse children and you think about those children who have who are nonverbal, cannot express themselves. That loss of routine means they lose their place in time as well as space. So you can imagine how disorientating coming into hospital is. Now imagine how disorientating that is to then lose your references to time. So a lot of families will build their family routine around, right, these medications are due now. Heidi, I think you had something similar with Charlie, didn't you?
Yes, yeah, we had an admittance. That was actually as an adult, just barely. But he'd just gone into that transition where I couldn't stay with him. And he called me very, very distressed at 3 a.m. in the morning because obviously his drugs had gone in, they'd all been locked away. He has, since the age of 5, required melatonin to sleep. He does not produce his own. And so he was laying there in a hospital bed. I think we were in there for 5 days. He was having a EEG done. Yeah, so I just put the phone down from him, ring the ring the main desk and say, go and give him he can't, it's melatonin. You know what it's prescribed for. It's 3 a.m. You should have had it at 10. Medications, and particularly if you're taking a lot of them, can be very, very hard to put into your daily life anyway. And you have little ways in which you bring them into your young child's life. Your little ways to just make that process easier. Charlie's been taking pills for years and years and years since he was very young. So you form it, and that does, like Adam says, it becomes that child's point of reference. And then when you go in, and even those little things that you maybe do slightly different to make the process more amenable, that child are no longer possible. They're not even listened to. And so it just adds, it's just another layer of distress.
Heidi, how did you find, or how do parents find their voice in that situation? I imagine that's really challenging to do.
It is, and there's many years where I didn't. I just let them get on with it and comforted my son, and he comforted, well, I think we comforted each other, because some stays were horrible, absolutely horrible. And I do find it, I went home with Charlie as a first-time 23-year-old mum. We'd been in hospital for 3 months with this firstborn, and we go home to oxygen 24/7, and I'm left to learn that. So you have to step up, and you learn and you research yourself, and you start to understand terminology and signs and symptoms and medication. And, this isn't something that as a parent, when you have a child that visits hospital regularly, this isn't something you tend to do alongside all your other hobbies. And it is consuming. What I found was I often felt very capable as a mum when they wanted to early discharge him to free up a bed after surgery. That was said so many times to me. You know him better than us. You know him better than us.
Until you walk through the door.
Till you walk through the door.
Yeah.
And then all the medications are taken away, locked away, the chart's put at the end of the bed. If you're lucky, sometimes I have known at one hospital stay, they saw me looking at the chart, and it was, from that moment on, it was removed.
Wow. That's quite powerful, isn't it? And speaks quite powerfully to the dynamic in the room.
This is a full-time job for us parents. It would be amazing, and I'll say that again. It will be amazing when we can get this brought in across the country. It will be amazing.
Yeah. And you said there about, going home and with oxygen, and sort of you then being considered competent enough to understand what you were doing. And I know in your work together that communication was one of your main themes that came out of this. So what can organisations do to improve that? Have you got any insight into that in terms of communication?
So for me, it's about bringing parents into those clinical assessments and conversations, and not disregarding the parent's history. As clinicians, we have our own preconceived ideas of the way things should present and the way things should look, but they don't. Every child is different. Everybody responds differently. So actually what clinicians should be doing is saying, how do you feel about your child today, mum or dad? How do you feel your child is doing today? The other aspect is giving parents choice and crediting them with the ability to make reasoned and rational decisions. A lot of the processes that we use in healthcare particularly around medicine's choice, are based on non-patient important things like cost and availability at the time and things like that. And actually, sometimes the cheapest product is not the best. I'm going to use paracetamol as an example, and nursing staff, medical staff who listen to this podcast will be nodding furiously in their cars or in the gym as they listen to this. We don't use Calpol in the NHS because it's branded and it's expensive, but we use cheap, generic paracetamol. The number of clinicians, myself included, who've had those doses of paracetamol spat into our faces because it tastes horrible. We would probably break even if we just switched to Calpol en masse, because the flavour is nicer, it's much more tolerable, it's what kids will take. And we saw examples of that in my PhD with antibiotics, children not taking antibiotics because they tasted horrible, they have a horrible mouthfeel, but hospitals unwilling to change to a more appropriate formulation because our guideline says, or it's too expensive. These are things that parents don't care about. They want to go home, they want their children to feel better. Give us the stuff we know they like, but we are too rigid about the way we apply our guidelines and our formularies. So really just kind of acknowledge parent need and experience and respect that and work with it.
Can we talk about when things go wrong in terms of medication? It seems from your research that sometimes parents are left to administer medicines, sometimes in the hospital setting, definitely at home where you have your own routines. We talked about routines a bit. But what happens in hospital? I know you mentioned, Adam, earlier, where there were instances where parents would then be having to administer or refusing to administer a medication because it was a different dosage to what they had known and used with their child, and then didn't feel confident in it. And some of that getting the staff's, the healthcare professionals' backs up a little bit about it. In terms of medication errors, are there any questions that are raised around sort of task allocation and risk management? How is that absorbed if there's no clear defined pathway about who's actually giving the medicine, whether it's parental responsibility, whether it's healthcare professional? How is that accounted for in a hospital setting?
Honestly, nobody knows who's doing what at any given time. So the assumption in most hospital organisations is, oh, nurses do all the medication administration. They don't. It's far more often that the parents will do that. And that's the difficulty. I think that's why there are many obstructions to parents administering medicines while they're in hospital, because there is no direct oversight. There's no control. Hospital organisations seek to control things. It gives them assurance that they know what is going on day to day. One of the big questions that emerged from that aspect of our study was, well, actually, who's responsible in a situation of a medication error? I mean, was I very lucky? Yes, I was very lucky. I didn't observe any significant medication errors while I was undertaking this study. I think that speaks to the inherent safety of the systems that we have at the moment. They manage, they do really, really well. But there is a fear of what happens when things go wrong. And I think that's because nobody's really addressed that. So something that has happened after our study that Heidi knows very well, we're now looking at how do we design a parent administration of medicines program that hospitals can use that will satisfy the need for control on the part of the organisation, but will also allow parents to exercise their agency and autonomy over their children. So we've just applied for funding from NIHR for that in the last couple of months. So, we definitely want to set that up. But at the moment, nobody knows who anything's doing. You talked about task allocation. It's literally who's around at the time that can do it. And if a nurse is there with a parent that they know or have a relationship with over that time, if they've got other things to do, they'll be just like, here you go, mum, there's your medicines. Go ahead and give them and let you know when you're done. What would happen when things go wrong? The parents become an easy get out. Oh, mum did it and mum did it wrong, which I suppose gives the hospital then an opportunity to say, well, we can't do anything about that. That's not ours. One of the hospitals had reported a number of parent medication errors while I'd been during the course of the study. And what they were doing was they just banned parent self-administration of medicines. That's just not feasible. Again, because it's an adaptation, because nurses are busy. They have too much stuff to do already. They're going to ask parents to give those medicines where they need the time and the space, so that banning parent administration isn't going to work, because it's just one of those under the table things that happens. But there is a fear that parents are going to do something wrong and we will have no way of preventing that. And when things do go wrong, parents become an easy way of shifting the blame and accountability away from the organisation.
Can you share what changes you would like to see across healthcare? Heidi, can I come to you first?
As a parent, even before you become a parent, certainly speaking from my own experience, Charlie was so wanted. We read the books, we knew he was this size, whatever, at 28 weeks, 24 weeks. And then we got to 28 We didn't see what was coming at all. That was not in our plans. Charlie arrived dramatically. Our whole future was turned upside down. His journey has been incredible. Our journey as a family has been incredible. And I have learned so much from him and from his conditions and about his health needs. What to say when you call an ambulance. God, I've got that pattern down to an absolute T. You know, I give them absolutely exactly the information they need it in order. It's embedded in here because I've done it so many times. You live such a very different life to parent at the school gate whose child does not have to endure these travels. I would really like to see that just given the credit that it's deserved when you take your child in. Listen to us as parents. We live, we breathe, we eat, sleep, and then we repeat all of this medical information day in, day out. We often don't take care of ourselves. We don't put ourselves first. Our children are constantly being, their needs are put before ours. And we know them. We know them. And even the subtle little signs, we're aware. I have met so many health professionals, I haven't got enough body parts to count. One has said to me, I'm going to trust your mother's instinct on this because that's far more valuable than anything I can bring to the table. He's the one I remember.
Yeah. Yeah. Listen to the parents.
Yeah.
Adam, what changes would you like to see across the healthcare system, maybe from a slightly different perspective?
Absolutely. Definitely listen to your parents, get them involved in care because they know their kids. If they're on oxygen, if they have a hole in their tube to help them breathe, if they've got a hole in their belly to let them poo, parents know what they're doing and they've got those little things. They know the bits that don't quite work, that the minute you go into hospital just isn't there. Get them involved. Let them teach you as a healthcare practitioner how to look after their kid because you're going to learn loads from that. The other one is trust their history. We have a habit amongst ourselves as healthcare professionals that we want to see. If it's not written down, it's not true. Sorry, what Heidi and people like her carry in their heads about the status and the history of their kids is verbatim. It is the truth. That is what's happening. I have this argument with junior pharmacists all the time when they're doing their medication history checks. They will ask the parent last after they have concocted this list from a load of different medical notes that half the time isn't true. And then because mum or dad give them a list of drugs that isn't quite the same, they say, well, mum doesn't know what she's doing. Hang on. That's what mum is giving their child at home, regardless of what we've got written down in our. Therefore, the best possible medication history, what this child is taking, is what you have just been told by the parent. Trying to get your head around that as a healthcare professional who has rules and guidelines they have to follow. I get that's really that's really weird, but it's about learning to trust somebody who isn't you. And that's where I come to epistemic injustice. We don't believe our families because they're not us. They don't use our language. They don't work in our circles. They're not often in our social class. And it's all those internal biases that we bring to bear on our families where we label them as pushy mum or challenging family. Actually, if you just took 2 minutes to listen to them and acknowledge that what they're saying is what they do at home and therefore is the right thing, will alleviate a lot of those challenges. So listen to your parents, get them involved in care. And then for me, as a last thing, Heidi said herself, she's never seen a pharmacist. She wished she'd met me 10, 11, 15 years ago because she's never met a pharmacist. I didn't see very many pharmacists on my research. If I did, they were locked away in a room with the door closed and they were just sat in front of a computer. And my big question as a pharmacist myself is my entire role is built around patient safety and making sure patients use medicine safely. If we're not doing that, then what are we doing? And that's a big question for me. And that's a big question, I think, for my profession is if we're just checking the work of other people, where is our value? Our value is actually in supporting and advocating for families that don't have that voice themselves.
Being visible,
Yeah,
visible pharmacy.
Absolutely.
Heidi, we'd love to plug your charity. Would you tell us about the charity that you work for and what they're advocating for?
I will indeed. I'll start by saying that unfortunately can only serve the people of Ryedale in North Yorkshire. When Charlie was first born, we were living in Essex. We were there during that first year of his life when he was on the oxygen at home, and there was no charity. There was nothing there. We moved back to my hometown when he was a year old. Within a couple of weeks, I had Ryedale Special Families in my life, and they're a charity that supports children, families with children with additional needs and disabilities from birth to 25. And Charlie stayed with them till he was 25, and they actually helped move him on in his new life. As still a relatively new mum and dad, they offer support, guidance, advice. And like I said to you before, they've been with us, which is why they knew the journey we'd been on us so well, because they had walked by our side and listened to me cry and sob and despair many times. It's often a very isolating journey, and certainly Ryedale Special Families' aim is to take away some of that isolation, whether that be through communication with the staff or through some of our groups or from fellow parental support. I often go to meet new parents and I'll say to them, this is who I am, this is my job, but I've been a parent. I often say we've walked the same journey, just in different pairs of shoes. And at that moment, you see them go, their shoulders drop and they will chat. We'll aim to support healthcare, social care, benefit system, and trying to help parents navigate this journey in where to apply for help with that application. As much as I would love to see what Adam has started spread right across the country, I would also like to see a Ryedale Special Families in every district of the country as well.
And it sounds like it's wonderful work that you are doing. And I think from a research point of view, you've so adequately highlighted what impacts actually bringing the lived experience voice, but also by working with the voluntary and community faith and social enterprise sectors can really embellish our research. You've both really highlighted the importance and the impact that research can have when it's done properly and includes that lived experience voice. So thank you both so much for taking the time today to talk to us, to help us do this special episode for World Patient Safety Day. Thank you everybody for listening. We've unpacked how medication safety affects young patients, their parents and caregivers, and why their experiences matter and what we can learn from the voices that often go unheard. Keep listening for our next episode in this World Patient Safety Day special, where we'll be talking about the safer care of preterm babies. As always, you can find more information in the show notes on our website. Thank you for listening to our World Patient Safety Day specials. Safe care for every newborn and every child. Let's work together to ensure patient safety from the start. See you in the next episode of Voices for Safety. You've been listening to Voices for Safety, the podcast that explores the forefront of patient safety research, brought to you by the NIHR Greater Manchester Patient Safety Research Collaboration. If you enjoyed today's discussion and want to stay updated on the latest in patient safety, be sure to follow us for upcoming episodes. You can also find us on X, Blue Sky, LinkedIn, and on our website www.psrc-gm.nihr.ac.uk. Join us as we continue to uncover insights, innovations that make healthcare safer for everyone. Thank you all for listening, and we'll catch you in the next episode.